Welcome to today's Explainer. We're diving into something as old as humanity itself, but let's be honest, it still brings a wild mix of awe, anxiety, and a million questions for new parents everywhere. We're talking about breastfeeding. Now, you always hear people say it's the most natural thing in the world, right? And biologically, sure it is. But what often gets left out of that conversation is that it's actually a learned skill. It takes practice, a ton of patience, and giving yourself and your baby a whole lot of grace. So today, we're going to break down the expectations, the reality, and some expert-backed solutions to help you navigate this entire journey.
Here is how we're going to tackle this today. First, we'll look at the magic of mother's milk. Then, how it's actually made, followed by perfecting the latch. After that, we'll solve some common nursing hurdles, and finally talk about building your support team.
Okay, let's jump right into Section 1, the magic of mother's milk and setting the ideal expectation.
Before we get into the actual mechanics of it, it's super important to validate exactly why you might want to take on this journey in the first place. Human milk really is the perfect food for babies, completely custom-made by your own body. And the wild part? The benefits are entirely mutual. Mayo Clinic data shows that breastfeeding gives babies this incredibly strong start in life. It actively decreases their risk for things like asthma, ear infections, obesity, type 1 diabetes, stomach bugs, and even sudden infant death syndrome. But hey, mom gets a massive health boost too. Nursing actually reduces a mother's risk of breast and ovarian cancer, not to mention lowering the risk for type 2 diabetes and high blood pressure. It is literally a biological feedback loop that protects the both of you.
All right, moving on to Section 2, let's look at how milk is actually made, the biology behind the magic.
So now that we know why it's so great, how does your body actually know to make this liquid gold? Well, during pregnancy, your breasts are prepping for it, but after birth is when the magic really kicks into gear. When you deliver, your pregnancy hormones suddenly drop. That signals a lactation hormone called prolactin to step up and tell your breasts, hey, time to make milk. But actually getting it out, that's a fascinating process. When your baby suckles, it triggers a second hormone called oxytocin. This sends a direct message to the small muscles in your breast to contract, which physically squeezes the milk down through the ducts. We call this the letdown reflex. It's this incredible bite-sized piece of biology where your baby's specific suckling literally operates your internal machinery to release their food.
But here's the thing, your milk doesn't just show up all at once in its final form. According to WIC guidelines, it goes through 3 distinct phases. For the first few days postpartum, your body makes colostrum. It's thick, usually kind of yellowish, and absolutely packed with protective antibodies. Actually, Mayo Clinic experts note you can even start hand expressing this stuff at 37 weeks pregnant if you want to jumpstart your supply. Then, around the first week when you bring baby home, transitional milk starts replacing the colostrum. Finally, by 10 to 15 days, you've got mature milk. It's a bit thinner, but it continuously adapts to your baby's exact nutritional needs. So if you're early on and anxiously waiting for your milk to, quote-unquote, come in, take a deep breath. This timeline is perfectly normal.
Which brings us to the reality of newborn feeding. 8 to 12. That is the bold, unvarnished number of times a newborn needs to eat in a single 24-hour period. I know, it sounds like a ton. Because their tummies are so tiny at first, it doesn't take much to fill them up, but it empties out just as quickly. The golden rule to remember here is to watch your baby, not the clock. You really want to look for early hunger cues, things like rooting from side to side or putting their hands to their mouth. Crying? That's actually the very last sign of hunger. And trust me, it is way harder to feed a frustrated, crying baby.
Now, with feeding happening that often, a huge fear for almost all parents is, am I actually producing enough milk? Instead of panicking, you can look for these specific, reassuring checkpoints. Is your baby content and satisfied after a feed? Do your breasts physically feel softer? And perhaps most importantly, pay attention to what's coming out the other end. Once your milk fully transitions, you should be seeing about 5 to 6 wet and soiled diapers a day. And of course, your pediatrician will be keeping a close eye on their consistent weight gain. If those boxes are checked, you are doing great. Your baby is getting exactly what they need.
Okay, on to Section 3, perfecting the latch. Let's do a reality check on this learned skill.
Getting that milk out efficiently is exactly where the learning curve hits. Early on, feeding sessions can take 30 minutes or even longer, and the absolute key to making those sessions effective and, crucially, preventing serious pain for you is perfecting the latch. A proper latch means your baby isn't just chomping on the nipple. They need to be gumming the areola to compress those milk ducts we talked about. So here's how you do it.
First, tickle the baby's cheek to stimulate that rooting reflex we mentioned so they open up nice and wide. Second, bring the baby right up to the breast while compressing the areola with your fingers. Third, check that their chin and the tip of their nose are actually touching your breast. And fourth, look at their lips. They should be flanged outward, almost like a little fish. If you're hearing clicking noises or feeling a sharp pinching pain, gently break the seal with your finger and just try again until you establish that nice rhythmic suck-swallow breath pattern.
But let's pause for a second. What if you try all of those steps? You were doing literally everything by the book, and it's still excruciating, or the baby just can't stay latched. Please, take a deep breath and ask yourself this. What if the problem isn't you?
Sometimes there's a literal physical barrier in the way. About 4% of infants are born with a condition called ankylosing, more commonly known as a tongue tie. This is where the frenulum, that little string connecting the tongue to the floor of the mouth, is just too short. It restricts their tongue movements so much that they physically cannot latch properly. Lip ties or having a really high arched palate can cause the exact same issues. The huge relief here is that if a doctor or lactation consultant diagnoses this, there's a very simple, quick, pediatric procedure called a frenotomy. It instantly frees the tongue and can completely transform your feeding experience. You aren't failing. Sometimes biology just needs a tiny little adjustment.
Let's jump into Section 4, Solving Common Nursing Hurdles. Think of this as your symptom-to-solution toolkit. Now, what's really interesting about this next part is that even with a perfect latch and no anatomical issues, your body is going through massive changes, and hurdles are going to pop up. Based on what to expect's medical guides, here's a handy toolkit. If you wake up with rock-hard breasts around 3 days postpartum, that's engorgement. The immediate relief, nurse frequently, use warm compresses before feed and cold ones after. Now, if you feel a red, tender lump, you've likely got a clogged duct. For that, apply warm compresses, gently massage just the lump itself, and make sure to drain the breast. If that escalates into a fever, body aches, and redness, it could be mastitis, which is an infection. You'll definitely need doctor-prescribed antibiotics for that. But notice the big common thread here. Whether it's engorgement, clogged ducts, or even mastitis, the immediate medical advice is actually to keep nursing. Stopping suddenly can make these issues a whole lot worse.
Another massive hurdle and a really common reason moms want to throw in the towel is sore nipples, or what are called milk blebs. Those are just tiny blocked pores right on the nipple. Listen, your skin will naturally toughen up in a few weeks, I promise. But in the meantime, to heal, let them air dry after feeds, apply a thin layer of baby-safe lanolin, and use cool compresses. If you've got a blocked milk bleb, applying moist heat right before feeding can help the baby's suckling pop that pore open naturally. It does get better, and finding relief is often just about sticking to these quick, soothing routines.
Let's contrast two very different supply realities. Low supply is a major fear for a lot of parents, and it's usually caused by stretching out the time between feeds too much. Because breast milk works on a strict supply and demand system, the fix is purely mechanical. Nurse more often, or do what's called power pumping between feeds to signal your body to step up production. On the flip side, oversupply is a very real challenge, where the rush of milk actually causes the baby to choke, or they might bite down just to stop the flow. If this is happening to you, try holding the baby more upright. Burp them frequently, and crucially, avoid extra pumping. Pumping will only tell your body to make even more milk, which is the exact opposite of what you want here.
All right, our final section, number 5, building your support team. Because you really don't have to do this alone.
So you've got the biological knowledge, the latching techniques, and your troubleshooting toolkit. But honestly, persistence alone isn't enough. Having a solid support network is what actually gets families through those fumbling, exhausted first few weeks. Never hesitate to pick up the phone and call your OBGYN, midwife, or pediatrician. For example, if you suspect thrush, which is a yeast infection that makes your nipples burn, they can quickly prescribe safe antifungal treatments. Lean heavily on certified lactation consultants. Their visits are often covered by insurance, and they are absolute wizards at adjusting feeding positions. And don't forget about local La Leche League representatives and public health nurses. They are entirely dedicated to helping you succeed, no matter what hurdle you're facing.
Ultimately, this beautifully illustrates a vital point. Breastfeeding doesn't have to be an all-or-nothing game. Exclusive nursing is amazing, it's highly portable, and it builds supply naturally. But combination feeding, where you mix nursing at home with pumping or maybe formula, is a completely valid, legally supported path. In fact, if you're returning to work, there are strict workplace laws designed to support your right to pump in an appropriate dedicated space. It is entirely about finding the balance that fits your family's unique lifestyle.
I want to wrap up this explainer with a really powerful thought from Amy Newman, a nurse practitioner and lactation consultant at the Mayo Clinic. She says, "The most important goal is for baby to be fed. We want new moms to feel they have the tools and resources they need to feed their baby and enjoy the process."
Now that you are armed with the biology, the toolkit, and the